Hi, everyone. Can you all hear us okay?
Yeah, we can.
We got some comments that some of the folks didn't see the invite, so that's why. All right, thank you for joining us for our SDI updates. And it'll be recorded and we'll share it afterwards. And the updates happen in 2021, so we want to kind of update everyone and ask questions and go from there. I'm Dr. V.
Hi, Dr. Horn. So welcome to this talk. This is going to be part 1 of 2, and we're going to talk about STIs, so sexually transmitted infections. And I think this is a really great talk, and you'll see why. We're going to talk about, the rates of STIs increasing and the importance of recognizing and treating correctly, and their new recommendations as far as how to treat. And so if you have any questions, please let us know. We're getting a lot of questions recently on STIs and what to do with these different patients. So this is really, really good topical thing to talk about.
Yeah. So we've been getting a lot of questions because, with COVID-19 pandemic, what has happened is a lot of the free STI clinics each state had, unfortunately, they were all pulled to do COVID-19 work. So there was not a lot of people following STI cases or having funding or time. So because of that, we're rapidly seeing increases in STIs, gonorrhea, chlamydia, syphilis. So let's talk about it, include HIV as well. That's for a different talk. So overall, the incidence of STI, 1 in 5 people who are in the US have an STI. And it's now considered sexually transmitted infection is the proper way to say, and not sexually transmitted disease. So we'll be using the term sexually transmitted infection. And we spend over $16 billion nationally to help with STI cases and costs. And as of 2019, so data for 2021, 2022 is still coming to, they're still collecting. So we only have data so far as 2020, so more to come. We had about 600,000 gonorrhea cases. We had about 129,000 syphilis cases. And we are also having kids born with congenital syphilis as well, which is very concerning. We'll talk a little bit about it more. And 1.8 million cases of chlamydia.
So here's the prevalence and incidence, and down here on the side, it talks about the difference between prevalence and incidence. Prevalence is the estimated number of infections, new or existing. So that's like a snapshot of the people that have it at that time. And then incidence is the estimated number of new infections. So the incidence of the new infections that are brand new. And so up here we have HPV, and you can see the prevalence is extremely high, and the incidence. I think this is really important. This really stresses the importance of HPV vaccination. This is one of those things where if you're seeing a patient, that and you see that they're not vaccinated for HPV, it'd be a really good idea to give them that vaccination. There are a few vaccinations that prevent cancer, and that's one of them. So when you discuss it with the patient, or you discuss it, if you're working with children, if you tell them this is something that prevents cancer, that would be, a way to kind of approach it. And I think, there are other vaccines, there are a few others like hepatitis B vaccine that prevents cancer. And that's really fantastic if you can, that's the way to approach it, I think.
Yeah, and I love that you said that, because not a lot of vaccines that prevent cancer, and we know HPV, a human papillomavirus, and also hepatitis B both prevent cancer. So really important to be able to advocate for that. I always think of it as never miss an opportunity to give vaccination. So when our patients are in our system, when they're coming in, it's so important to keep that part of our language and ask about vaccine status.
And it can not only cervical cancer, but also in men. They look at like anal cancer, rectal cancers, and it's completely preventable. So if you have someone, even if they're, and I think they've kind of opened up the age range.
Yeah.
And so, if you ask them, have you ever had this vaccine before? That'd be something, and whether they're coming into your practice or they're coming from another country, it'd be important to ask them if they've had it, ask them if they're interested in preventing cancer.
Yeah.
Just,
And the other thing to remember is that we are seeing increased incidence of oral cancer, head and neck cancer. So everybody has different sexual practices as well. So it's really important that to help people get HPV vaccine because it can prevent head and neck cancer as well.
and then we have HSV, trichomonas, chlamydia, HIV, gonorrhea, syphilis.
So all of these diseases are increasing in numbers. So it's really important to make sure we keep all of this in mind. And again, it's another way to look at how much dollars we are spending, $1.16 billion. 25% of the cost are for females, and 26% of the cost that we are spending is for youth, 15 to 24 years of age. So these two groups are really high risk as well, and we really have to focus on screening for sexually transmitted infections.
And then as far as the negative impact of STIs, so if you look at the rise in ectopic pregnancies, and then people having issues trying to conceive, infertility treatments, salpingitis, these are all things, that negative impact of STIs. Yeah,
and another thing to remember is if you have a sexually transmitted infection, you are at really high risk for getting HIV as well. So, that's another major complication. So kind of making sure we treat them appropriately. So chlamydia infection among adolescents and adults. So very high prevalence if you're less than 24 years of age. In 2020, total of 1.5 million cases. For example, we live in Nebraska and Omaha, and we have really high cases of like chlamydia and gonorrhea. And certain women who are diagnosed with just, for example, chlamydia, they're pretty asymptomatic. You check them and they're positive. A lot of the time they might be asymptomatic, but they have ascending upper genital infections already. So even though it looks very simple and mild case, they're starting to have complications that we don't know about. So it's really important to test and treat.
And then as far as rates of reported cases, this is among women aged 15 to 44 years, and you can see, the different age groups here. So it's really important to screen. And I think this really shows the importance of screening.
And this is, again, remember we said earlier, this data is only until 2020. So what I'm hearing, what we're understanding is that rates are going up. So we took a little dive down, meaning we were going in the right direction. But now what we're really worried about is it's going to go up again. So that's what I'm hearing as well, because of after COVID-19, and we don't have data yet for 2021, 2022. So more reasons for us to keep a close eye.
Yeah, and the U.S. Preventative Task Force, when they make recommendations for how often you should be screening people, if someone has multiple partners or they're sexually active, you should be screening them every 3 months. And so that's from the U.S. Preventative Task Force. And, if you see them and they haven't like chlamydia and you treat them appropriately, it's still important to stay in contact with that person to make sure that they, don't get it again since they're still at high risk.
And the other area, so when patients come in, the pattern is a lot of time patients go to their primary care provider. But a lot of patients also come to ER and urgent care. Mm-hmm. So it's really important ER and urgent care to remember these things to screen as well when they come in for these type of symptoms so that we are not missing.
Oh yeah, that's a really good point, because a lot of people that when they get diagnosed with STIs, if you look back, it turns out they actually saw like either their primary care or ER, they saw a clinician in the last few months. And so it's really important to kind of keep that in mind.
So how does chlamydia show up in men? So they could have urethritis, so discharge, pain in the penile urethral area. And it's sometimes you could have dysuria, mild to moderate, and discharge, white to clear discharge can be seen as well. Sometimes you could have another infection called Mycoplasma genitalium, which we'll talk about the next lecture, part 2. And then you could also get epididymitis or proctitis. So there's a lot of different ways a chlamydia can show up. And 15% of proctitis are in homosexual males. So it's really important to like think about gonorrhea and chlamydia, and also the testing at the right site as well. And so now they recommend testing gonorrhea and chlamydia not only in urine or urethral area, but sometimes you have to do swabs in the rectal area or mouth. So it's really important to test for other sites as well.
And then with women, cervicitis is most common, and then sometimes they have no other symptoms. And if they do have symptoms, you're thinking mucopurulent discharge, urethritis, salpingitis, and they can develop infertility, ectopic pregnancies. I mean, this is something that, so even if someone has no symptoms, you should still, if you're discussing the risk factors and they're at risk, still consider, testing and testing even without symptoms. And then other people, so they can get other infections, endometritis, Fitzhugh-Curtis syndrome, which is a very bad infection, Reiter's syndrome.
Yeah, Fitzhugh-Curtis syndrome is interesting because it looks like they get infection with gonorrhea, chlamydia, but then they also get these string-like adhesions, right, with your liver and your intra-abdominal area. So it's really important to, like, sometimes when you have liver affected too, it's think about Fitzhugh-Curtis syndrome. And then Reiter syndrome too. If patients present with like recent STI, but then they have like urethritis, they have issues with their eyes, conjunctivitis, pain with arthritis, and then they also have skin lesions. It's a board question in ID.
Yeah, I think med students, they can't pee, can't see, can't climb a tree. I think that's what med students say as far as remembering it.
So it's important to kind of keep these in mind because STIs can cause this. I'm glad you remember that.
I know that's from med school from a long time ago. Chlamydia diagnosis. So culture, only about 70% sensitive. So what does that mean? So instead of culture, we're thinking more like NAT testing or PCR testing is the way to go. And they'll talk about the good and the bad of PCR testing with gonorrhea, chlamydia. When they do a PCR testing, you're more likely to get the diagnosis, you're more likely to identify it, but they don't do susceptibility testing. So they don't do testing with which antibiotics will work or not work. And so it's more of a challenge now to kind of follow and see what antibiotics work and don't work. And as things become more resistant over time. And so that's why it's really important to follow, the recommendations as far as, every few years they'll come out and make recommendations for increasing the dosage or what drugs work and don't work.
So one of the big concerns people are fearing is gonorrhea.
Yeah.
Because we're starting to see a lot of resistance, and the guidelines that we're talking about right now, they change the dose of some of the drugs because of gonorrhea resistant. And because we have such large number of gonorrhea and chlamydia, it's so important to treat because we don't want to get resistance and having to do IV therapy. But so I would say takeaway from here is if you're worried about chlamydia, do a PCR testing.
Mm-hmm. And as far as treatment, so recommended regimens for chlamydia infection among adolescents and adults: doxycycline, 100 milligrams orally twice daily for 7 days. And then alternative regimens, you can give azithromycin or levofloxacin. So if someone, if you're not sure if they can take it for 7 days or they're going to take it for 7 days, you can give them a 1 gram dose just in the ER and watch them take it. And that way you can, make sure that they've gotten the appropriate treatment for it. Levofloxacin is also here. I don't know that I try not to give levofloxacin for this. I'm not sure if this is a new recommendation.
It's on the CDC website. So these are alternatives, but ideally doxycycline is your best, or azithromycin ×1. And also to remember, when you're pregnant, unfortunately, you can't give doxycycline because it hurts the baby's bones and cartilage and teeth. Just changes color, but you don't want to have brown teeth when the baby's growing up. So it's really important. You could do azithromycin in pregnancy, which is safe. And then of course, alternative is amoxicillin. You know, whenever you give alternative, it's not the best, but you could do that.
Yeah, azithromycin, as far as macrolides, sometimes they can increase peristalsis, and they can cause a little bit of GI kind of feeling funny, your stomach kind of rumbling because it's increasing the peristalsis. So sometimes people may vomit it up if you give them a large dose, but a lot of people that I've given it to, they can tolerate it.
Yeah,
okay. Yeah. So it's something to think about if they take it and vomit it up, but most of the time they can take it and they do just fine. Yeah.
So we always get a question about, like, if you had chlamydia, when do you retest, right? So test of cure, it's important in pregnant females because if they still persistently positive or got reinfected, high risk for ectopic pregnancy miscarriages. However, in men and women diagnosed with chlamydia should be rescreened about 3 to 4 months due to high risk of like reinfection, especially adolescents. So you could rescreen, but you don't need test of cure. But for females who are pregnant, you should do a test of cure, make sure they're okay because of the baby.
Yeah, and one of the things we're worried about, it's not so much that the antibiotics didn't work, it's that they got re-exposed,
Yeah,
right?
exactly.
So, and that kind of depends, I think, what state you're in as far as treating the partner, but we'd always urge them to treat their partners and everything.
Yeah. In 2021 guidelines, they are asking now to be lenient with partner treatment. So they're really asking that if you have a partner of a patient, being able to treat them much faster, being able to give them prescription and treat them, because otherwise it's just going to, continue to perpetuate, and then the patient will get exposed again. So being more quickly being able to give a prescription to the partner, or making sure the partner comes in to get checked.
Yeah, I support that.
Yes.
And gonorrhea. So 2020, a lot of cases of gonorrhea were reported, making the second most common notifiable sexually transmitted infection in the United States for that year. So rates of reported gonorrhea have increased 111% since the historic low of 2009. So with it increasing, this is why this is such a great topic to talk about, to think about it. Even if you haven't seen it in a while, it's important to keep it in your mind as far as what patients you're seeing and should you be testing them.
And here's a really nice picture comparing 5 years, right? 2015 to 2020. Again, no data for after 2020, but most of the states are now in dark blue, which means really high rates compared to lower rates 5 years ago. So it's just a nice visual illustration of cases are increasing. So we really need to test and treat.
Yeah, it really looks like it's increasing all over the country. All the places are getting darker.
Yep. So again, prevalence are highest amongst adolescents. Asymptomatic infection can range in women 25 to 80%, and men 1 to 3%. Transmission is highest male to female. Co-infection with chlamydia can happen in male about 50 to 25%, and women even higher, 30 to 40%. So you could have both infection at the same time, and asymptomatic infection is really high too. That's why we should be screening the high risk groups, especially an adolescents group who are less than 24 years of age. We should be screening them. And
this co-infection is really important. I mean, whenever someone has one STI, then it's important to screen for a lot of the others, right? So if someone has one, say they have gonorrhea, it's important to also think of chlamydia, syphilis, HIV, and
Thank you for saying that. That's a really good point. Yeah, so don't just screen for one thing, right? Like I always get HIV as well.
Yeah.
Nationally, HIV rates are also affected and going up. So if you're thinking about screening your patients, please get HIV, gonorrhea, chlamydia, and syphilis. And then when I see my patients, I don't make it a taboo when I tell them, I screen everybody for, sexually transmitted infection. It's really important to screen, we're just doing a screening test, because sometimes it's how you talk to the patient too, because otherwise they'll get scared. And, especially when you say HIV. So I think it's important to say we're just screening, and it's recommended by CDC. CDC actually recommends HIV testing for over 13, I believe, up to 64, at least one time in their lifetime.
Yeah, I think that's a really good point because yeah, I do it the same way where I'll say, have you ever had an HIV test before? And sometimes they'll say, oh, yes, I had one, a couple months ago, which is great. And then sometimes they'll say, oh, I've never had one. And I try to do the same thing where there's the stigma kind of with HIV
Yeah.
that, but you shouldn't be not testing them because of the stigma, but and I do the same thing where I say I don't see anything in the labs that indicates you would have HIV, but I think it's really important to test, and the U.S. Preventative Task Force recommends testing for everyone,
Yes.
if you've never had a test before, and sometimes with the teams if we recommend to the hospitalist team to test for HIV, sometimes they won't test and they'll say, oh, he goes to church, and there are actually articles showing that people that go to church get diagnosed later than if they didn't go to church because they don't get tested for it. And
yeah, I just think it's important to just keep it as healthcare issue, right? And then just make sure this is our routine process.
Oh yeah, no, and that's with national exams.
And not fall into like other biases that we might.
Oh, exactly.
Have.
Right. Yeah, that's the importance of not trying to think about your own bias and who you test and who you don't, and
exactly,
and treating everyone the same way.
So I get asked a lot of questions about PID, and pelvic inflammatory disease can happen with gonorrhea and chlamydia, and what it means. So you have inflammation internally. You could have internal abscess, chronic pelvic pain, damage to your fallopian tubes, and this leads to ectopic pregnancy and infertility, right? So I think it's really important to cover about PID, and the new guidelines also recommend new treatments, additional treatments. So let's go over them.
And this is the minimum clinical criteria present on pelvic exam. So it has cervical motion tenderness or uterine tenderness or adnexal tenderness. And so really, I think, if there's a question, I think it's really important to be very aggressive in treating anyone where it's suspected. And so, I think with these, they try to make the minimum clinical criteria very, very minimal.
Yeah.
So it'll include a lot of people because it's very important, as far as sensitivity to identify as many patients as possible. And then one or more of the following additional criteria can be used. So this again is not very much to make these. So it's an oral temperature, 38.3, this cervical mucopurulent discharge, presence of abundant numbers of WBCs, elevated ESR, CRP, and cervical infection with gonorrhea or chlamydia. So it doesn't take too much to make this, but I think it's really the point here is to try and identify as many patients as possible.
Yeah, and it's really important to do a vaginal exam and a cervical exam. So to look at the cervix, is there a discharge, and also is there like friability? Is the cervix like bleeding easily? So that's another. So it's really important as providers we keep in back of our mind, and also to do a good vaginal exam.
And then as far as organisms involved, so all regimens used should be effective against gonorrhea and chlamydia.
And they also say negative endocervical screening for these organisms does not rule out upper genital tract infection. So if your suspicion is high, but negative cultures or tests, you should still treat it. And in 2021, what they're recommending is not only do you treat for gonorrhea and chlamydia, but they also find now that anaerobic organisms are involved in pelvic inflammatory disease as well. So they are recommending like organisms like Bacteroides, right? It's a common anaerobic organism, but we should treat for that. So what they're recommending now is for PID with the regular regimen to add metronidazole. So we can go to the next slide. So this is what they're recommending as of 2021 guidelines. If you're suspecting PID, you do ceftriaxone, 1 gram IVQ 24 hours. You do doxycycline, 100 milligrams every 12 hours, plus metronidazole 500 Q12 hours. And then what they're saying is if the patient is sick enough and they're getting admitted to the hospital, you could do this 24 to 48 hours. And if they feel better, then you could discharge them on oral. On top of PID, sometimes it gets infection to the ovaries. Then you have to at least keep them in the hospital for 24 hours, make sure. So what they're saying is ceftriaxone, doxy, metronidazole. And on discharge, you do doxy and metronidazole, but it's a 14-day regimen, 2 weeks regimen. So for pelvic inflammatory disease, it's 14 days and add anaerobic coverage would be the big takeaway from 2021 guidelines.
And then as far as recommended intramuscular or oral regimens, so they're looking at ceftriaxone, 500 intramuscular in a single dose, plus doxycycline, plus metronidazole. So this is something that, in a single dose, and then plus doxycycline and metronidazole for 14 days. So it's really important, when you're trying to decide who can I give kind of doses where I'm going to plan on PO versus it's essentially inpatient versus outpatient is kind of the way I think of that. Is that kind of how you think of it?
Yeah, too? I would keep like patient on unstable, severe abscess, vitals are not good, inpatient, treat them at least 24 to 48 hours, stabilize, then send them on oral. But if somebody comes to your clinic or ER and you think they have PID, but it's okay and they're stable, then you could give an IM shot of ceftriaxone and then send them home on oral doxy and flagyl. But just remember, PID now requires flagyl as one of the agents.
Yeah, there are some things that, some types of infections where I really want to be really aggressive. And, I think these are the ones.
Yeah.
If I'm thinking of, do I want to err in the side of undertreating or overtreating? I really want to err in the side of overtreating and being extremely aggressive with these types of infections.
Yeah, especially knowing that it can cause infertility and scarring. It's really important to treat out patients.
The complications of gonorrhea. So gonorrhea may be complicated by epididymitis. Rare cases may lead to infertility. Men or women, you can think about disseminated gonococcal infection. And so disseminated gonococcal infection, a lot of those patients get arthritis, tenosynovitis. Now, disseminated, I think of that as essentially bacteremia.
Yes.
And then bacteremia that's going in seeding places, right? So, and gonorrhea, when it comes to diagnosis, I think it can be a little bit more difficult when it comes to culturing or trying to get a PCR test, but it has to be on someone's mind, if they have a single large inflamed joint like a knee, it has to be kind of on your mind, because if you just tap it and you just do a regular culture, you may or may not identify it.
Yeah, so they have PCR and for other sites, so it's really important to send PCR. And honestly, I think I've seen one patient in my 10 years of being an attending endocarditis a long time ago. But so it's really important to think about disseminated infection from gonorrhea, because I think I've seen several joint infections as well. Yeah. I'm sure you have as well. So it's really important to think about it and treat it.
As far as diagnosis, so you can do Gram staining culture. Really, the best way to do it is PCR, GC chlamydia PCR, and so PCR of the urine is one of the good ways to do it. So yeah, I don't know what your thoughts are about I think culture versus PCR.
I think PCR is the best way to do it. Quick diagnosis, treatment. Because culture takes so long, and then also you have to have the right medium to culture. So I think for most of us, PCR is the best way. And in other fluid like joint and stuff, if you don't have in hospital, you could always send it out to get PCR as well while you're treating the patient.
Oh yeah, anytime I'm considering it and a culture is being done, I'll call the lab and say, hey, one of the things we're worried about is gonorrhea. I just, want to touch base with the lab and just make sure that they're aware. An uncomplicated gonorrhea infection of the cervix, urethra, or rectum.
So again, just a quick overview, 500 milligrams of IM single dose ceftriaxone. If chlamydia infection has not been excluded, treat chlamydia with doxycycline 100 milligrams twice a day for 7 days. Recommended regimen uncomplicated pharynx, infection of the throat. Again, ceftriaxone IM single dose, 150 milligrams, 500 milligrams. And then if the patient is larger and BMI 150 kilos, then they recommend going to 1 gram of ceftriaxone.
And I've had those questions before too, where people will call and they'll say, hey, you know, my patient's pretty big. Is it okay if I give a larger dose? And I'm
Yes.
totally fine with giving large doses to people, you know, especially if they're a large person.
Yes.
But yeah, then they'll say, oh, you know, is it okay if I give 1 gram or 2 grams? They'll say, especially if they're thinking about other infections that the patient may have and they want to cover really well. And yeah, I try not to underdose people.
Yeah. So, and beta lactams like ceftriaxone is safe to bump up the
Right.
dose. So
Yeah,
it's
they're
really,
not gonna
yeah,
overdose on ceftriaxone. Yeah.
So you should be okay with that as well. Alternatives, if some reason you cannot do ceftriaxone, you could do cefexime orally, or you could do gentamicin IM single dose plus 2 grams of azithromycin. These are alternatives if you need it, but ideally ceftriaxone 500 milligrams or 1 gram for higher weight.
And syphilis is, you know, the number of people with syphilis is increasing. And this is also another one that I've been getting a lot of questions lately on patients with really bad syphilis. And so here's the total number of syphilis cases you can see are increasing. And this is a really good one to talk about as well.
Yeah, so it's really concerning too. So as you see, it's increasing here, going in the wrong direction. So if you go to the next slide, what you see, it's very concerning. After 2019, the green line, which represents women, have really increased with syphilis. So in 2020, syphilis in women have tremendously gone up, especially in childbearing age in women. So, which is really concerning because rates are going up, but now the demographic woman, it's gone up. So if you go to the next slide, this is what I'm worried about. So women are in orange line, babies are in blue line. So babies getting congenital syphilis from mom is just going up. So in 2020, we had over 2,100 cases of congenital syphilis and over 149 stillbirth due to congenital syphilis. I have not seen this high of a rate in a very, very, very long time. So this is really concerning to me.
Yeah, public health. This is a big public health issue.
Yeah.
Preventative health, public
Yes.
health. Yeah.
And that's why we as healthcare workers have to think about it and screen our patients. And we'll talk a little bit about screening. So when it comes to syphilis, there's different stages: incubation period when they're not symptomatic, primary, secondary, latent, and late tertiary. So we'll go through that. And you had a really nice resource over here.
So I have a picture of this. This is from New York City Department of Health, and they came out with this document. It's a really great PDF, and you know, this came out in a couple of years ago, I think.
2019, I believe.
2019, but it's not only does it describe, you know, some of the treatments, but it also goes into really in depth about the different stages, how to diagnose, and it has some really good illustrations in there and pictures of, you know, their patient examples and everything. And so whenever, you know, I get questions on syphilis, especially if I get very specific questions, I'll link to this document. I'll text people the link to it, and they can look at it and see, you know, a very clear explanation, because syphilis can be pretty complicated, and it's really so valuable to have something that talks about it in a very simple way. And so when I look for this, I'll just go to Google and I'll type in New York syphilis PDF, and I'll Google image it, and this will pop up, and I'll click on it, and it's really the most simple explanation about syphilis that I can find.
And early disease, infectious during primary. So people are very infectious during primary, secondary. So the rash is one of the things that you think about. Sometimes you get lesions on oral or genital area, but you also get a typical rash. Incidents are going up, highest in young folks, 30 and younger, 15 to 30 years of age. And if a patient has syphilis, the transmission is the average patient, they have 3 other contacts and 50% transmission. It's very high. So that's why it's really important to think about syphilis and treat.
And then this is one of the images from that document that I was discussing, the New York one. So people get exposure, incubating infection. They have primary, secondary, early latent, and late latent. And then when it comes to neurosyphilis and ocular otic syphilis, that can occur also. And really, there's on the right here, tertiary, late neurosyphilis, late ocular otic, and you can see around 6 months, 12 months, and then 1 or more decades later, you can get the late stages.
So that's so important. What you're showing is like, if you don't diagnose them early, by the time it hits 6 months, you get into neurosyphilis, ocular syphilis, so many other late complications. So we have to test early.
And when you're thinking about primary, and if they have a chancre, sometimes people may not realize, because it's a painless lesion, they may not realize that they ever had a chancre.
So yeah, thank you. Leading into primary is when you get a lesion, it can be smooth and firmed and raised, and it's usually not painful. Usually can be on mouth, genital areas. Secondary is when you get rashes, and one of the classic thing for syphilitic rash is palms and soles. So syphilis rash, palms and soles. And then when we see palms and sole rash, we think about like Rocky Mountain spotted fever, syphilis, hand, foot, and mouth disease. But syphilis should be one of your diagnoses, differentials, when you see hand and foot lesions.
And these chancres, I think it's important what you said about it can be in other locations.
Yes.
And if you have men who have sex with men, they could have a rectal chancre.
Yes.
And it's non-painful, so they never even knew they had it.
Yes. And latent syphilis is asymptomatic, detected by serology. So that's when we do RPR, VDRL. And then late or tertiary syphilis is when you have neurosyphilis, you have issues with your hearing, confusion, headaches. Also, you could have cardiovascular, aortic root, can have dissections. You could have bone, liver, skin lesions. So syphilis, master masquerader, right?
The great
mass. Yeah, so it can affect any area, and it's really important to think about. So overall, again, neurosyphilis, meningitis, it's important to keep in mind. We're getting into detail, but we'll send the slides out.
As far as diagnosis, there's dark field exam, but it's not done anymore. So the labs won't. If you ask them for dark field, they'll say, that was something in kind of historical. And now they have tests, and we'll get into some of these in the next few slides about the traditional and non-traditional testing. And neurosyphilis, if you're concerned about neurosyphilis, then you would be doing an LP and examining there. And when to do CSF, when do you do an LP? Anyone that has syphilis with any kind of neurologic or ophthalmic or symptoms. So if they have any eye issues, they have any neurologic anything. That's kind of how broad I have it.
Like ear issues, like ringing in your ears and things like that. Any other, you should be doing a LP.
And as far as serology, so you have VDRL, you have RPR, and I think we can look at this a little more when it comes to the algorithm. So here's the traditional syphilis screening algorithm. You start with an RPR, and they look at it kind of as here it is, treponemal testing. So syphilis specific and non-treponemal testing. So syphilis, I think of it kind of syphilis specific and non-syphilis specific. So RPR is a non-treponemal test. And if it's reactive, then you do the treponemal testing. And if it's reactive, you have a syphilis infection. And if the RPR is positive and then the treponemal testing is negative, you have a false positive. Now, this is the traditional way of doing it. And on the next slide, and this is the traditional way. And then this is the reverse sequence. So this is, they do it kind of in a opposite way. So instead of doing the RPR first,
And the reason that they don't do RPR first anymore, because it takes hours to do it. So now they're trying to make the lab go faster. So they do the syphilis specific test first.
Yeah, and so to save money, right?
Yes.
So New York started, I think New York started doing
Yes.
this first, and
Yes.
then they showed how much it saved money, and then so if you're doing like a like ideally when you're looking at how you want to do these things, you ideally want to do the sensitive test, then the specific test. But here you're kind of doing the specific test, then the sensitive test. You're doing it backwards. But so when we put this into our computer, we don't put in RPR anymore. We put in syphilis screen, and they do it backwards.
And so syphilis treatment, penicillin is your best friend. So if it's primary, secondary, early, latent, you do benzathine penicillin 2.4 million units times once. Remember, benzathine penicillin is different than procaine penicillin. Benzathine penicillin half-life is like long, 10 to 14 days. That's why you just do one shot. Procaine penicillin half-life is very short. So it's really important to know for primary syphilis, benzathine penicillin 2.4 million times once intramuscular. Latent, you could do 2.4 intramuscular once a week for 3 weeks. But latent syphilis with normal CSF, again, once a week for 3 weeks. Or you could do benzathine penicillin 7.2 million units total at once. Neurosyphilis, however, so if you have neurosyphilis, ocular syphilis, then you have to do IV penicillin. That's when you have to do a midline or a PICC line, and then you do a penicillin for 10 to 14 days.
And I've had some questions on this about giving it, every 4 hours. And some of the patients are going to be discharged home, and every 4 hours dosing is kind of a lot. But if you could do it on a pump,
yes,
and then they can put it in, over a 24-hour period, and it'll just run continuously. So they just fill it up once per day, and then it will continuously run in over 24 hours. It's really the easiest way.
Yeah, completely agree.
Easiest way to do it. And then when it comes to titers, so and I had this question also recently about a patient that had syphilis in the past. Should they be rechecking titers? What's important when they recheck titers? And if you do, now when you treat someone, you can recheck their titers a couple months later. I think they recommend about 4 months, but I'm okay actually doing it a little earlier than that, to make sure the patient, that their titers are improving and looking better. And so recheck their titers, make sure it's going in the right direction.
Yeah, then next slide. So again, in women, making sure we treat them appropriately, especially when they're pregnant, right? To prevent moms to get it, but from getting a syphilis passing on to the baby. But also they recommend sometimes if mom has latent syphilis, early syphilis, secondary, sometimes it's okay to give a second dose of 1 week later of 2.4 million units. It's part of, and this network, National Network for STD Clinical Preventative Training Center, has really great resources as well. And again, pretty similar. It's important to retest moms at 28 weeks of gestation to make sure we prevent congenital syphilis. And just follow up for serology, following up after treatment. If it's serology is coming down nicely, you're okay. But if it's going up, then you have to think about re-exposure. Do you need to retreatment? So more to come. But I want to be cognizant about time. It's 1:02. And also for neurosyphilis, if there's so lack of decline in your titers, and if it goes on the wrong direction, it's important to consider LPing and retapping as well. And I think we could stop here, the last slide. One of the most important thing is when we're getting sexual history from our patients, how we ask in a non-judgmental, kind way, and telling our patients that sexual history is important for medical history. So, maybe phrasing the questions like, may I ask you a few questions about your sexual health and sexual practices? At this point in the visit, I generally ask some questions regarding your sexual life. Will that be okay? do you have any questions or concern about your sexual health? Just, you know, having open-ended question and being able to have that dialogue with your patients is important. I think we're going to stop here, and we will do part 2 coming up next year, and then we'll go over the rest of the STIs and who to screen and when to screen.
All right, great. Any questions at all?
Have you all been having any gonorrhea, chlamydia, or syphilis cases? Any question or PID cases? Please let us know if there's any of these complicated cases that come up. We are happy to help and answer questions, and let us know what other topics we could also cover for next year. But we'll do a part 2 with the rest of the STIs coming up soon. Thank you so much.
All right, thank you, everybody.